start. Good morning, everybody. Thank you for joining us today. It's my pleasure to introduce Dr. Luke Webster. Dr. Webster is a health sciences assistant clinical professor in the Department of Nephrology and Hypertension at the University of California, San Diego. He earned his medical degree from Creighton University and completed his residency and fellowship training in internal medicine and nephrology at UC San Diego. During his residency, he served as chief medical resident, leading efforts in mentorship, curriculum development, and education. He is now core faculty for the Nephrology Fellowship Program and plays an active role in teaching both fellows and medical students. He also serves as co-director of the Advanced Nephrology for the Consultant Conference, a program designed to support ongoing education for consulting nephrologists. Clinically, Dr. Webster has a special interest in the management of chronic kidney disease, particularly in patients living with HIV. So, his research has been published in peer-reviewed journals and focuses on urinary biomarkers and kidney replacement therapy. Please join me in welcoming Dr. Luke Webster. And I see your screen is already up there, so take it away. Welcome, Luke.
Thank you so much for having me, and thank you for the kind introduction. I'm really excited to speak with everyone here today about an interest that's very dear to me, and that's really about evaluating chronic kidney disease in patients who have HIV. So before we jump into the discussion, just want to let you know I have no disclosures. So how did I get interested in this topic? And I will say doing residency at UC San Diego, I had a pretty good experience working with the Owen team, doing inpatient HIV rounds, going to the HIV discussions. But I found that when I transitioned over to the nephrology side of things, focus was really just on general chronic kidney disease care. And as I've been establishing my panel over the past 2 years, I've noticed, many consults coming in from our Owen faculty. And I recognized that perhaps there was a big hole in some of our training in how to approach these patients. And so I'll give you some examples. And these are patients that I've seen in clinic. I had a patient in their 60s with history of HIV since their 80s, currently with an undetectable viral load. They did note a 10-year history to TDF, had hypertension and stage 2 chronic kidney disease. And the evaluation was for microscopic hematuria. And that always leads to the question, is this something like an acute GN that could be associated with a chronic infection? Or is it something more benign like prostatitis or nephrolithiasis? Another patient, with undetectable viral load in their 50s, diabetes, hypertension, stage 3A chronic kidney disease, found to have nephrotic syndrome. Is this something like HIV-associated nephropathy or HIVAN? Or something that's more common in the general community like diabetes-related nephrotic syndrome? And then lastly, a 60-year-old patient with undetectable viral load, hypertension, MGUS, and stage 3B chronic kidney disease, found to have low-grade proteinuria. Did I need to be worried about something like FSGS, which we call focal segmental glomerular sclerosis, or is this something that's more common like paraproteinemic kidney disease? And so that really led me to focusing and trying to educate myself on this topic. So what are we going to review today? So I'd like to kind of briefly discuss the epidemiology of patients with chronic kidney disease and HIV. I'd also like to examine some specific risk factors for chronic kidney disease in these patients as well. We're going to briefly touch on some of the common renal pathology, specifically trying to highlight what seems to be more common in this era of antiretroviral therapy. And then lastly, I'd like to leave you with a more practical hands-on approach of how a nephrologist would recommend maybe monitoring these patients in your clinic. So as we start our discussion, I just want to set an even page for everyone with the terminology that I'll be using. And when we are discussing chronic kidney disease, nephrologists, we really like to use this KDIGO kind of heat map. So recognize, kidney function is defined by GFR, and the less GFR you have, the more advanced your chronic kidney disease. And in many of the studies that we see, chronic kidney disease is typically labeled as stage 3 to stage 5. And so that's really anything with a GFR of less than 60. Sometimes the studies will include a CKD stage 2, and that's a GFR less than 90. The other side of this heat map is the proteinuria or albuminuria heat map. This is important because, proteinuria is abnormal, and some of the studies just use a GFR criteria, whereas other studies will include a proteinuria criteria for CKD. And we'll talk about a little bit of how that is impactful when we look at the epidemiologic data. So before we jump into specific HIV risk factors, I want to give us an overview of CKD risk factors amongst the general population because there's a lot of overlap. So of course, we know that things like diabetes, hypertension, metabolic syndrome, and obesity, they play a huge role, especially in the United States. Chronic kidney disease is a growing problem, probably due to these three main issues. Other big risk factors include things like heart disease or coronary artery disease. Certainly, we know that if you have a strong family history of CKD, that your risk of developing and having progression of CKD is much higher than the general population. Tobacco use is huge, especially if you already have CKD. It's why we're so adamant about counseling tobacco cessation in these patients. And then a big one, but certainly a not modifiable risk factor, is aging. It's typically thought that after the age of 40, every person will lose about 1 to 1.5 milliliters per minute of GFR throughout the rest of their life. So by the age of 60, this would mean that most patients have lost anywhere from 20 to 30 milliliters per minute of kidney function just by aging alone. And we'll talk about how aging is now becoming a much more important risk factor for our HIV patients. And then a last one that's important to keep in mind is acute kidney injury. So, acute kidney injury, in many cases, I think, especially in internal medicine training, we think of it as it's a little bit benign in many patients, right? Someone has a stage 1 AKI or a stage 2 AKI, and by the time they leave the hospital, kidney function's back to normal. But from a nephrologist perspective, we know that any acute kidney injury event leads to loss of kidney function. The more severe the AKI, the bigger the loss of kidney function, and the higher your risk of developing and progressing in stages of chronic kidney disease. So where are we kind of as a whole? So at least in the US, up to 14% of patients are estimated to have CKD. So that's about 35 to 37 million in just the general population. And when we look at that distribution across age, that distribution is highest in elder patients who are over 65. Up to 33% of patients over 65 are estimated to have chronic kidney disease. And then that number in the 40 to 60 range is about 12%. When we look at the distribution among men and women, we see that women actually have a higher proportion or a higher prevalence of chronic kidney disease. We're not going to dive into this in our discussion today, but perhaps there's some factors that are propagated by pregnancy. And then when we look at, ethnicity, we see that, patients who are non-Hispanic Black, non-Hispanic Asian, and Hispanic have higher prevalences of chronic kidney disease than non-Hispanic whites. The highest risk of chronic kidney disease in the general population is in non-Hispanic Blacks. And I think this is an important demographic to keep in mind as we start to transition over to HIV-specific factors. Now, if we broaden this to the world, the world tends to have a little bit lower stage or a lower prevalence of chronic kidney disease. So maybe in large population studies, about 10 to 11% of patients worldwide have stage 3 to stage 5 chronic kidney disease. And if we look at patients of their 60s and 70s, the highest risk is in the 70s worldwide, with about 28% of patients having CKD. So now that we've set the stage, let's now transition back to looking at patients who are living with HIV. And I would say that at least colloquially or based on, first-person experience, myself and my colleagues, we tend to see a lot of patients in clinic or a lot of patients in the hospital presenting with kidney pathology, certainly more so than our general population. And so when I first turned to the data, I was trying to get a sense of, what is really the overall prevalence of chronic kidney disease, specifically in patients with HIV. And I will say that the studies are incredibly challenging to interpret. First of all, there's a lot of heterogeneity in how they were done. They're small sample sizes. Specifically, studies that are looking worldwide are using different markers or different equations to estimate kidney function. And so that kind of makes the data a little bit hazy. But I will offer you 3 things to keep in mind when you're looking at some of these large observational studies. So we know that chronic kidney disease is driven by aging. And so when you look at the general population, there is a good spread of individuals in terms of age in those cohorts. If you look at the studies in HIV positive patients, they tend to not have the same age distribution. So perhaps we're losing an important factor from aging alone. Second is that, there was really no good definition for either muscle mass, inflammation status, and nutrition. So just remember, if you are using a patient who is severely malnourished, very low weight, that's going to affect their serum creatinine, and that could either cause them to present with, quote, CKD or not with CKD. And then lastly, a lot of the HIV studies that looked at epi data did not include urine protein evaluation. So they only went off of, serum creatinine. And I think that could mean that we're missing a lot of patients that perhaps had kidney pathology in these studies. So with that, let's go to what the data says. If we're looking at the rates of chronic kidney disease stage 3 to stage 5 in North America and Europe, the studies will estimate that anywhere from 4.5% to 10% based on one study, or anywhere from 2.5% to 17% of patients with HIV have chronic kidney disease. There are some studies that try to specifically look and include urine proteinuria, and they found that if you use that factor up as high as maybe 30% of patients could meet the criteria of CKD. Now, if we look specifically at patients who are African or of African descent, that risk of CKD suddenly jumps to much higher levels, anywhere from 3.5% to 48.5% of patients. And once chronic kidney disease does develop, we do have good data that those patients are at much higher risk of progression to end-stage kidney disease or dialysis than the HIV negative individual. And that risk extends even to patients who are of African descent. 18 to 50% increased risk of progression to end-stage kidney disease over their non-African counterparts. So while I know almost everybody on this call is probably practicing in San Diego or in Southern California, but just given, the spread of HIV worldwide, I wanted to give you just a glimpse of the data, kind of what is seen outside of the US. And I will say that at least according to this one meta-analysis, the rates in Africa and around the world don't seem to be hugely different. But I will say that the African studies tend to include other metrics that we don't use in the US. They're still using Cockcroft-Gault. And so perhaps that's why there's a slightly different skew in Africa. But I wasn't really satisfied kind of with that data. So I wanted to present one small cohort that perhaps gives us a slightly more consistent glimpse of what's happening in the real world with these patients. So this is one small study done in Japan. It had almost 2,000 patients in a single center. And they were specifically looking at the prevalence of CKD in their patients that came to their clinic. And of their patients, 94% were virally suppressed, 91% were on a protease inhibitor, integrase inhibitor, in an RTI or in RTI. The median time from HIV diagnosis to the study was about 9 years, and the median duration of antiretroviral therapy was about 7.3 years. And so you can see on the right, they found that their overall prevalence of CKD was about 13% amongst the entire cohort. But what I found really notable is that if you start looking over here in the 60s and certainly in the 70s age range, the prevalence of chronic kidney disease jumped to 47% at the oldest cohort, and about 30% in the 60-year-old cohort. Things like diabetes progress with age as well, with 16% of patients developing diabetes, 44% of patients developing hypertension by the age of 70, and 50% of patients developing some form of dyslipidemia. And, really what
Hey,
I think
Luke.
Yes.
So sorry to interrupt. There was a question on the slide before, I believe. Yes. So I'm sorry, hopefully it's just a clarification question. Could you comment on the differences in kidney disease between African versus African American people? I don't know. Maybe I guess it doesn't come up on the slide. Maybe you'll talk about it later as well.
So we will talk a little bit about it, but I can kind of dive into it now. So
well, if you're going to talk about it later, that's fine.
Okay,
we'll hold it.
Okay, I might answer it later, but if I don't, please hold me to it, and I'll circle back to kind of what some of the data is suggesting.
Sounds great.
Yeah, because we're going to talk a lot about genetics, and I think genetics is going to kind of play into answering that question. Okay, so let's see. So I think really what this study shows is that perhaps if we're looking at a real world example, amongst patients who are actually doing well in terms of viral suppression and in terms of, engagement in care, that chronic kidney disease does seem to be more prevalent in our patients with HIV, especially as they age. And when they looked at some of the metrics in their study, they found that three things perhaps, predicted development of CKD. So history of AIDS had a high odds ratio at about 1.5. A longer duration of antiretroviral therapy actually had an increased risk at about 1.07, very slight, and then a longer time from diagnosis of HIV infection. So I think, some factors is that the longer patients have lived with HIV, the longer they've perhaps been exposed to some of these therapies, that is driving some of this risk factor. So now that we've talked a little bit about epi data, I'm going to start to build out a heat map of our own, specifically for patients with HIV. And don't worry, we'll work through this all bit by bit. So, and I think this ties into a little bit of the question of why perhaps patients of African descent or in Africa versus African descent, and we can talk about that some more. But one thing to consider in our patients is that there are a couple of genetic risk factors that will really accelerate progression of CKD in patients with HIV if they have them. One of the biggest ones that I think is still being researched and still being understood is the APOL1, G1 and G2. So APOL1 is a protective genotype, especially against Trypanosoma brucei. And so it is a genotype that really we see in patients of African descent. And I will say that perhaps the one population that has a slightly lower prevalence of this genotype, I think, are patients from Ethiopia. But otherwise, especially patients in South Africa, I think have a high prevalence of containing this or having this allele. Now, we know in patients who do not have HIV that APOL1 is a huge driver of FSGS and progressive kidney disease. Patients can develop, have a higher 4% risk of FSGS if they have this genotype. Patients who have this genotype and have HIV are at an incredibly high risk of FSGS, and certainly for HIV-associated nephropathy, odds ratio of 17 to 29. And in fact, the highest risk includes patients who are South African, and that can include a lot of other social factors. I'll show you a biopsy series that was done out of South Africa, and it really suggests that perhaps there's a lot of secondary infections, there's differences in antiretroviral therapy, and there is lower rates of viral suppression that could be driving some of the pathology with worsening kidney function in those patients. There is a little bit of a signal, perhaps, that patients who also have sickle cell trait have worsening progression of CKD. This is not well defined, but I will say that we know that patients who are sickling in their kidney, that is just driving chronic, microscopic damage in the kidney itself. And so that's an additional risk factor. Another one that probably has not come up on any of your radars is that there is probably a risk for developing tenofovir nephrotoxicity. Some patients have this ABCC2/4 variant, and basically it means that they're at higher risk of intracellular accumulation of the drug. And perhaps that could be what is leading to some differences in who develops tenofovir toxicity on TDF versus who doesn't. So now let's move to social demographics. So as I mentioned before, age is a huge driver or a huge risk factor for CKD. And I think, we live in a modern era where patients have access, especially in the US, to amazing therapy. They're living, to this near the same age as their HIV negative cohorts. With aging, that is opening up our patients with HIV to developing a lot of those chronic medical conditions that perhaps we have not seen in the past 20 years or 2 decades. According to one study, up to 54% of patients as of 2022 are over the age of 50. We also know that, race or ethnicity does seem to play a role in risk factors for chronic kidney disease. If we look at patients with HIV in the US, about 40% of them are Black or African American, and 29% are Hispanic or Latino. Illicit drug use is another big risk factor for chronic kidney disease. And I think if we just look at the population as a whole, some patients with HIV have a higher risk of either an IV drug exposure or a non-IV drug exposure. About 16% of patients are maybe estimated to have used IV drugs once in their lifetime. And this, just opens up secondary kidney pathology. Cocaine can be contaminated with levimicol, causing like Inca vasculitis. IV heroin can cause, collapsing FSGS, or even just chronic IV drug use can lead to amyloidosis. And then lastly, but certainly not least important, is that, a low socioeconomic status is bad for all markers of health. And one of those markers is chronic kidney disease. So it's an independent risk factor amongst all patients for developing CKD and CKD progression due to poor housing insecurity, poor access to food, and maybe lack of access to care. And I think, unfortunately, we still see that a lot of patients with HIV in the US have a higher risk of being of a lower socioeconomic status.
Luke, I'm sorry, there was a quick question about the genetic tests that you mentioned on the slide before. Are they commercially available to screen patients of African descent? Are these used in practice much, or is this, more of a research?
This great question. So I would say in the kidney community, we are now starting to screen for APOL1. I will say that there has not yet been, so this is stepping back from HIV specific, so general population. We don't yet have a directed therapy for specifically mitigating risk of APOL1 yet. Maybe give us 15 years and we'll have something. But the Natera test is a widely used genetic screening tool that is specifically focused on traits for kidney pathology.
And covered by insurance?
So in almost all patients, it's covered by insurance. Cool. And I will say the company has been incredibly generous since I've been working with them. If it is denied by insurance, I have yet to have a patient actually billed. So they've told me to my face that they will eat the cost if it's not covered, and also if there's a big copay. Like let's say they cover 80% of the test. I haven't had a patient even get a 20% copay. That's great. I think at least in the nephrology community, we tend to use Natera most commonly just because it's really nice and focused. It won't test this ABCC2/4 variant, I think because it's still considered a variant of unknown significance, but it will definitely test for APOL1 and other, specific nephrology-focused genes. I think there's another big company, Natera, Invitae is another ginormous company. Our group specifically does not use them as frequently, just because we have a good working relationship kind of with Natera, but there's no specific benefit or negatives to using one company over the other. Perhaps it's just whatever you have easy access to in your community or in your practice. Okay. So kind of, moving to our third set of risk factors, that's really focusing on all of those chronic medical conditions that we've seen throughout our medical training, right? We all know that diabetes and hypertension are big risk factors. And I just want to kind of highlight that diabetes itself seems to be a very large risk amongst patients living with HIV. And what do I mean by that? I mean that there does seem to be some data that suggests that patients with HIV who are on antiretroviral therapy tend to develop diabetes at a slightly higher rate than, say, their age-matched counterparts. And your group probably knows much better than me all the specific risk factors when it comes to antiretroviral therapy itself and the types of antiretroviral therapy. But I just wanted to present this one study that suggests that, HIV patients who have been on antiretroviral therapy, 7% risk of diabetes over 10 years as compared to maybe 2%. And there's a lot of, fantastic proven benefits of antiretroviral therapy, but they perhaps do play a chronic role in some of these medical processes over time. Other things like hypertension and cardiovascular disease are very important to keep in mind as well for these patients. I do want to kind of highlight acute kidney injury. So I mentioned on my first slide that acute kidney injury is important in all patients, but I think it's especially important in patients with HIV. And so what do I mean by that? I think if you are part of the Owen group who do inpatient HIV rounds, or certainly me when I was a resident here at UCSD, we see patients who are admitted in the hospital who have, infections, who are severely ill, and we see a very high rate of acute kidney injury in our HIV positive patients. And that could be due to many factors. And just to highlight how high of risk these patients are, they have 2 to 3 times the risk of acute kidney injury compared to their HIV negative controls. And if you're looking in the ICU, patients have up to a 66% of acute kidney injury. And so I think this is an important risk factor to keep in mind, just because of all the secondary medical conditions that can develop, especially in an inpatient population. And then last two, but maybe not as much data, malignancy. We know certain malignancies are more common in patients with HIV. And so certainly if they're being exposed to more cancer-directed therapy, that's a risk in and of itself. Perhaps there's some role for traditional or herbal medicines. I would say that's a general discussion for all patients. We typically don't recommend anything that is contains aristolochic acid. The only time patients can be exposed to that are if they're using a Asian herbalist. So sometimes there's some compounded herbs that contain perhaps aristolochic acid. All right. So moving to kind of now finally the HIV specific risk factors. And I will say that, these include just really high levels of HIV viremia and certainly immunosuppression or low CD4 count. So we know that in very high levels, HIV is associated with apoptosis of cells in the kidney, as well as dedifferentiation of the podocyte. And it's really kind of those two findings that typically lead to the classic pathology of HIV-associated nephropathy. And I want to say, there's been huge progression and big shifts in the types of antiretrovirals, specifically the ones we have access to here in the United States. But I just want to, highlight one that I think everyone is very familiar with, from the past decade or so, maybe closer to 2 decades. And that's really tenofovir, right? And specifically TDF. And the reason I want to highlight this is because I think there's a large proportion of patients now who have been on this therapy in the past. And we all know, we've probably all seen it, cases of AKI or, severe kidney pathology, low phosphorus. in patients who are on TDF. But the reason I want to highlight this as a specific risk factor for patients is that there is evidence that patients who were on TDF had a subclinical decline in their kidney function that perhaps was not picked up on, general screening for in the computer, or the creatinine that you see pop out on a lab report. And so there's this one study that was done back in 2010 that really showed that patients had an average GFR of 74 milliliters per minute before TDF. At the end of being taken off TDF, that dropped to about 51 milliliters per minute. So if you remember, that's like going from a CKD stage 2 or perhaps no CKD at all based on the computer system that was used to now CKD stage 3A. And this GFR does not significantly recover even about 13 months after coming off of the therapy. And so I highlight this because I think perhaps a lot of patients had some subclinical GFR decline that is now catching up with them now that they're aging and developing some of these other chronic medical conditions. So driving CKD forward. Okay. Lastly, I just want to kind of highlight, patients are at risk of developing secondary infections. The biggest ones that probably have drivers in terms of CKD progression are hepatitis B and C and tuberculosis. Tuberculosis certainly much less common probably here in California, but certainly if you're practicing or involved in patient care in Africa, that's an incredibly higher risk amongst that population. And, if patients have HIV, CKD, and hepatitis C, their risk of progression is almost 3 times that of an hepatitis C negative individual. Syphilis is an important driver, and perhaps a lower extent parasitic infections. So taking that all together, right, we have our genetic susceptibility, we have specific socio-demographics that drive susceptibility. We have all of the chronic medical conditions that we just see in the population at large, and then we have some specific HIV factors and high-risk infections. And those are really the factors that set up chronic kidney disease or acute kidney disease in these patients. And that leads to a very wide range of pathologies. And I promise I am not going to drag everyone through all the different types of kidney pathology. I simply put this slide up to know that there is a lot that is going through our heads as we're doing our consults on these patients. Right? Probably the biggest ones are podocytopathies, HIVAN. If you were practicing back in the early 90s, you probably saw this fairly routinely. We're now seeing a lot of FSGS, and FSGS is focal segmental glomerular sclerosis. That's just where the glomeruli tends to scar down for one reason or the other. We're also seeing things like immune complex mediated kidney disease. This used to be called HIVIC, if you've heard that terminology in some of your training. The nephrologists and the nephropathologists are now turning that into immune complex mediated kidney disease due to X. So a little bit of a tongue twister and a much broader pathology. And then you have other things that affect other parts of the kidney, like tubular interstitial or certainly vascular. So I just want to kind of pause on 1 second and just, because I know this is something that comes up and it's a question that comes up, really like HIVAN versus immune complex kidney disease due to HIV. And I bring this up just because of the history of this finding in patients with HIV. So HIVAN is a nephrotic syndrome. It's a collapsing FSGS. It really occurs when you have high levels of viral replication, causing, cell cycle dysregulation and cytoskeletal dysregulation in the glomeruli. This causes podocyte dysregulation. You also have a lot of, inflammation in the tubules, and all of that together kind of presents as that acute nephrotic syndrome. It was much more common back in, the early 90s, 1995. Almost 80% of all kidney biopsies showed HIVAN at that time. And I'll show you that is much, much, much less prevalent in today's day and age. It was even down to 30% about in 2004. Now, on the flip side of the HIVAN coin is now this immunocomplex kidney disease, or what we used to call HIVIC. And this really seems to be starting to play a bigger role amongst our patients as we're moving forward in time. And I think that is because we have patients who are living longer with HIV, and we have patients who have been very well controlled in terms of, being undetectable on modern antiretroviral therapy. And this is a really insidious disease. This is something that we can't prevent as of yet. And it's really where you have very low levels of this HIV virus that are perhaps binding just those normal polyclonal antibodies that are circulating. And that just forms immune complexes. And over time, those immune complexes develop and accelerate. And that leads to some of that pathology. And I think we will continue to see more immune complex kidney disease as we move forward in time, especially with our aging cohort of patients who have HIV. So now I want to kind of transition specifically to what we're seeing in today's day and age. And this was a really excellent biopsy series. So this is at least, this was done by Columbia. It was published in 2019. And from a huge number of biopsies, they pulled out about 430 of them that were HIV positive. Of those patients, the average age was about 53 years. 66% were male, 58% were Black, 25% were white, 17% were Hispanic. You notice that there was almost 0 patients who were Asian in this cohort. So perhaps leaving a void in terms of interpreting it for that specific patient. 80% of patients were on antiretroviral therapy, and 57% had diabetes, 31% with, 57% with hypertension, 31% with diabetes, 27% did have an HCV co-infection. And so what did they find as being the most common pathology amongst these patients? The top 2 diagnoses were immune complex mediated GNs and diabetic nephropathy. Much less common were HIVAN and tenofovir toxicity, followed by FSGS NOS. And I will say FSGS NOS is kind of a catch-all category. It just means they couldn't decide what was causing FSGS in that specific patient. But it is an important thing that we are seeing more and more in our HIV positive patients. But I think what is more telling is perhaps this graph. And, the data is a little bit messy, so we're just going to kind of look at the general trends. But this is taking the most common diagnoses in 2010 and comparing it with the most common diagnoses if you move forward in time to 2018. So perhaps back in 2010 and 2012, we're seeing a little bit more tenofovir toxicity. We're seeing more classic HIVAN, maybe a little bit less diabetes and less FSGS. But as we're moving forward in time, probably with the changes in antiretroviral agents, we're seeing diabetes jump to be the most common cause of kidney pathology, at least in 2018. Second being FSGS, and we see HIV-associated nephropathy and tenofovir toxicity drop way down in prevalence. And so I think this is only going to continue to accelerate. I mean, we are almost 10 years ahead of where this study was published. I would be interested to see an update from this research group if this trend has held true, or if we're seeing any differences in pathology like that immune complex mediated disease maybe becoming more prevalent than we are seeing in this slide. So transitioning a little bit to a broader perspective, we aren't quite seeing the same data if you're looking at patients who are from Africa. So this is a very similar biopsy study. This one was done in South Africa. They tried to look at, 4 different time periods: early antiretroviral therapy, the introduction of TDF, TDF-based fixed dose therapy, and then antiretroviral therapy at time of HIV diagnosis. And they were kind of looking to see how pathology and biopsy trends changed over time. But you can see, the rates of antiretroviral therapy use are only 65% in 2020. The rate of HIV suppression improved from 20% to 43%. They were doing biopsies at much higher creatinine, and I apologize, this is in not in US units, but we're not going to dive into like the stage too much. So just know that they were doing biopsies later as time went on. HIVAN did decrease from 45% down to 29%. And then interestingly, tubular interstitial disease became much more prominent, about 33% of patients. And so this suggests that, if you're working outside of the US, keep in mind that HIVAN, tenofovir toxicity, and certainly granulomatous disease can play a huge role of driving kidney pathology in some of these patients. And the researchers in this study really felt that it was due to exposure or high rates of exposure to tuberculosis in this population. And also, this group is still receiving a higher prevalence of TDF-based therapy, probably compared to our US population. And so that could be driving specific pathology in these patients. Okay. So we have, just a few 5 to 10 minutes left. I really want to leave everyone with perhaps a more practical approach to how to perhaps approach these patients, specifically from a nephrologist perspective. I know a lot is, there's a lot of individual factors, a lot of medical factors that go into choosing antiretroviral therapy. And me and my group, we all support using the right medication for each patient. So this is just a perspective if you're considering, a risk of chronic kidney disease in mind. I will say there has not been a lot of research that really shows, goal-directed medical therapy specifically in an HIV cohort. So a lot of what we are doing as nephrologists is we're trying to extrapolate data from our CKD cohorts and then apply it to patients with HIV. And hopefully, as we move forward in time, we'll have better data on some specific goal-directed therapy. So one strategy is when you are seeing your patients, perhaps keep in mind or perhaps split your focus on if your patient is at low risk of CKD versus high risk of CKD. And at least from, KDIGO, which is our, global consensus cohort, is that a low-risk patient would be someone with a normal GFR, so GFR greater than 90, has no proteinuria, and is at a younger age. Higher risk could be anything from, having some, borderline CKD, GFR less than 70, having some proteinuria, like 500 milligrams or more, and being over the age of 60. And certainly if they have hepatitis C co-infection, immunodeficiency, diabetes, uncontrolled hypertension, or cardiovascular disease. And the idea is perhaps, on a global scale, if your patients are at high risk, at least from a kidney perspective, perhaps try to minimize or avoid some of these higher risk agents like tenofovir, atazanavir, indinavir, and lopinavir. But if they're at lower risk, follow your local guidelines. Now, I put an asterisk up here to remind me, a lot of times it comes up, well, how are we supposed to estimate kidney function in these patients? And so really, the consensus is to use the CKD-EPI equation. And just know that if you're practicing here at UCSD or at the VA, probably in most health systems, CKD-EPI is the most common calculator that is built into the electronic medical record system. There have been studies specifically looking at HIV patients, especially patients who are well controlled, who are at a normal muscle mass. CKD-EPI accurately predicts GFR in patients with HIV. Now, if you are with us here at UCSD, you may ask the question, well, what about cystatin C, right? That is a metric we here use all the time. Perhaps it hasn't rolled out as commonly in the community. But cystatin C is a possible second factor that could be used if you're ever questioning the diagnosis or the GFR that you're getting with a creatinine-based measurement. But I wanted to show you this table because both of these values can be affected by both medications and chronic conditions. So if we're looking at serum creatinine, just know that things like older age, inflammation, and decreased protein intake, and certainly malnutrition will all falsely decrease your creatinine. And so if creatinine is decreased, it's going to falsely elevate your GFR. Same thing as can be the opposite. So increased muscle mass, if you have someone who's on testosterone or happens to be a bodybuilder, certainly some medications like dolutegravir, rilpivirine, certain antibiotics, and then certain pharmacoenhancers like ritonavir and cobicistat can increase creatinine. So just keep that in mind if you're seeing some numbers pop up that don't quite make sense when you're screening your patient. Cystatin C, I would say, it is less based or it is not based on muscle mass because it comes from any cell that has a nucleus. But certainly we know that older age, hyperthyroidism, inflammation, steroids, malignancy, and obesity can all falsely elevate your cystatin C. And other things like hypothyroidism can decrease your cystatin C. And so I would just say, use it with caution, but certainly if you have questions, that is what we are here to help you answer and to help you determine on, is this a concerning number or is this a number that might be explained by other factors? So,
Luke, just giving you it's 8:47, just a
okay.
time heads up.
This is my last, well, 2 last slides.
You're perfect then.
So what is perhaps a monitoring strategy to kind of keep in mind as you move forward with your patients in clinic? So I would say that a good time to screen for kidney function or screen for CKD is at the time of HIV diagnosis, at the start of antiretroviral therapy, and at any time that you change or modify your antiretroviral therapy. Part of this is a GFR assessment. So that's, your basic metabolic panel, but I would also include a UA. So I would recommend screening for proteinuria at every time that you are checking in with your patient. Certainly, if you have any concerns about unexplained CKD, AKI, any change in kidney function that is rapidly progressing, any new or worsening proteinuria, that is really a good flag to reach out to your nephrology colleagues to make sure that this isn't something secondary or something that needs a specific treatment for. Now, your low-risk patients could probably get away with being screened once a year for their kidney function. So that would mean, BMP once a year and a UA once a year. Certainly, I would also include the caveat of if you're changing their antiretroviral therapy, that is a good time just to get a BMP and a UA perhaps right before and consider getting it a month after. I know that's a little conservative, but that's the nephrologist in me. If they're high risk, you should be doing probably at least twice a year check-ins in terms of BMP and UA. If you do get a positive flag in terms of urine protein, please get a microalbumin to creatinine to really quantify the proteinuria so that can be tracked over time. And then if they are, or if they happen to be on TDF plus ritonavir or cobicistat, these patients probably need a little bit closer monitoring. So that includes, adding serum phosphorus in. That includes, your proteinuria assessment. And that includes, at least twice a year follow-up, maybe more if you start to notice any lab abnormalities that could be related to the tenofovir. Okay, I'm going to skip this slide, but we can come back to it if it's specific questions. But I would just like to thank everyone for your time. I've enjoyed sharing kind of my interest in CKD with you, and I'd like to open the floor to any questions.
I didn't mean to rush you. You had a few more minutes. It depends on sometimes how long this conversation goes. Sorry, I took over for Anik because she is not an MD, even though she does everything very well. I thought it might be a little bit smoother if I did it. And I actually thought I was moderating today. Anyway, Luke, thank you for such a great talk. I think it's been a while since we've had a talk related to kidney disease in patients living with HIV. I'll start with a question that got asked by Nettie Aldis about halfway through the presentation. Nettie, I don't know if you'd like to unmute because you sort of had a two-part question. I can ask it if it's hard for you to do that.
No, sure. Can you hear me?
Yeah.
Yeah, I was just typing here. What a great talk. Thank you so much. It was very relevant to those of us who are taking care of patients in clinic. So really, really appreciate it. About halfway through, or after you mentioned tenofovir, you said something like, I think that this sort of subclinical tenofovir exposure is sort of coming back to get people later in presenting with CKD, you know, later in their life. But it was sort of, it seemed like it was a, it was your opinion that that's probably what was contributing, but I wasn't clear if we really are, how much we're aware of that yet. It's such a relevant topic to our patients, most of whom have prior tenofovir exposure. So I was just wondering if you could expand on that. Like, do we have studies of people who had subclinical, you know, CKD changes, they've been on tenofovir, they're on something else now or whatever, and then later develop kidney disease, you know, what that association is? I'm not talking about acute tenofovir toxicity. I'm just talking about your comment that maybe the subclinical years of exposure are then leading to people's higher risk, you know, later in life.
Yeah, so great question. So I do think we do have data that there is some subclinical decline amongst patients, but I would say that it's not every patient responds to tenofovir in the same way. So some patients seem to have a higher rate of decline compared to other ones. I mean, we do know that patients who have been on TDF, there's been studies, I think, out of a group up north, Stanford, if I believe, where they've actually been able to track tenofovir in hair follicles. So we know that there's, you know, a high level of exposure. And certainly this study, I think, highlights that there is, you know, on average subclinical decline as patients move forward. And certainly there's, you know, decline that doesn't recover. And so it's a little bit my perspective, but I do think there is data that suggests that patients who have been on tenofovir is certainly for a prolonged amount of time. You know, we're talking probably maybe 5-10 years. Certainly, I think there's been some loss of GFR that is then setting them up to be at higher risk of CKD, perhaps as they move forward in aging and have more chronic medical conditions as they age.
Great, thank you so much.
I don't know if you can see the questions. I'll just read them for people who can't see them. Sanjay asks, and I think this is probably on a lot of people's minds, is there any reason to prioritize GLP-1 use for renal protection in patients living with HIV who also have diabetes?
I would say yes. So I would say that kind of if your patients have diabetes, if they have any abnormalities in their urine, you're kind of, I would say 3 medications should be kind of at the forefront. They should be on an ACE or ARB, as I'm sure everybody is already doing. I would recommend SGLT2 inhibitors. And then I would recommend, you know, GLP-1s specifically for diabetes in these patients. I think it was semaglutide that was in the past year specifically approved for chronic kidney disease in patients who have diabetes. And so our group is now putting patients on this as kind of I did not coin this term, but we're calling it, you know, kidney goal-directed medical therapy. You know, if you're familiar with goal-directed medical therapy from the cardiac perspective. So I would say absolutely, I would support that.
And I don't know who posted about that abstract from the VA, because I think this is all sort of in the same. Oh, actually, I don't know if the person from I'm not exactly sure what this is saying, because I don't know if that's TDF on PrEP in the VA. I don't know if the person who posted that wants to. Alfredo, I don't know if you can unmute and you wanna share this. Maybe you can't. I think you're just sharing sharing the abstract that with individuals taking TDF related to PrEP, that there was a reduction in GFR of 6% after 1 year and 8% after 5 years, if that's how I'm reading that.
That might have been answering my question too.
Right. Which I think also goes to the question the question from Sarah about recommendations for patients taking TDF who, Luke, as you're probably aware, is fewer and far between in patients living with HIV, but certainly we still see it for patients using it for PrEP, and probably more heavily at the VA than at many other places where I think TDF, TAF, gosh, I can't speak. TAF FTC is becoming more common. But any recommendations about phosphorus?
So I would say that phosphorus can be a helpful marker in flagging a patient who is perhaps developing signs of tenofovir toxicity. And that's just because of the proximal tubulopathy, or the far extreme is the Fanconi syndrome. And so it can be kind of like the canary in the coal mine, that something's going on that you need to pay attention to. So I think it's helpful, especially if you have patients who are still receiving TDF. But I agree, now that we're in a TAF era, I think I have only perhaps seen one patient in practice so far that was still receiving TDF as a common therapy. Almost everyone, if they were on tenofovir, was on TAF, which I think is going to be amazing as we move forward in time with patients who will hopefully have never been exposed to TDF from this point onward.
Right. And I would say to what Sarah was saying, it's certainly not recommended in the PrEP guidelines to, check phosphorus. I guess I would think that if a creatinine had bumped in some way, if you were following it up, maybe you would check a phosphorus at that time. But I certainly wouldn't. I wouldn't be checking that regularly. I don't know if Luke, that jives with how you would practice.
Oh yeah, so like, let's say you have a low risk individual who's on PrEP, who's young, who has really no medical conditions, who has no current kidney pathology. I agree. I think that it's not necessary unless you start to see something change. But certainly if they're on some of those higher risk, let me get the right, certainly I think if you have anybody on that TDF plus a boosting agent like the Cobicstat or ritonavir, I think if you have some of those secondary medications, that would be maybe a flag to kind of increase your level of monitoring or your level of suspicion.
Right.
But for someone on PrEP, as long as the creatinine is stable, I agree. I don't think it's a mandate to have to check phosphorus every single visit for them.
Yeah.
And for those that are on TDF, because I think in my previous practices I would have agreed that we're in more of a TAF era, but my current practice, there's still a good amount of TDF, and for probably pretty good reasons. You are suggesting checking phosphorus in those patients still taking TDF twice a year, correct?
Yeah, I mean,
Okay.
I would say it will be very patient-centered, right? So if you have a patient who's on TDF in your practice who perhaps falls into maybe more of a low risk for CKD, perhaps less important. But certainly I think if they're at high risk of CKD progression, I think that would be a cohort that I would suggest including phosphorus in your twice a year evaluation. Does that answer your question?
It does. Thank you. And I also think it's interesting. And I think there was a comment about this too. Is Truvada is still generic, and it may be one of the only options for people for PrEP because of cost consideration. So I do think it's an interesting thing that still needs to, at least for the next few years while Descovy is still on patent, we have questions about, are we doing harm? Should we be fighting harder for Descovy, et cetera? So
I mean, we've had
thank you very much.
years
This is
experience
interesting.
with it, and lots of studies that show that in an overall young and healthy population that is using it, and obviously there are exceptions, we really haven't seen significant issues. And I don't think there's, I mean, I think people do very well on TDF FTC. But I think then Jeff made a really good point, and he was talking about patients living with HIV, but with defunding, how can we track the development of CKD? And I'd say patients living with HIV and also patients without HIV on PrEP over time. That's sort of a scary thought.
Mm-hmm. Yeah, and I think I saw, I'm looking through the chat. Yeah, it's really the long-term TDF exposure. That's the highest risk category. And, certainly I am less educated on kind of the different ways to take PrEP, perhaps, like an on-demand versus a chronic exposure. Perhaps if your patients qualify for more on-demand PrEP, that would certainly lower the total cumulative dose of TDF. And so I think those would be incredibly low risk. It would be nice if we had the perfect system, if we had free and easy to access TAF, because I think that's the lowest risk. But I agree. I think if you have a young, otherwise healthy patient who's not going to be on TDF chronically, for years or decades, I think the risk of tenofovir toxicity is relatively low.
And I think that will be the final word as we're 2 minutes after. Sorry about that. This was great. Really appreciate you coming in and sharing your expertise and passion. We're going to definitely have you back if, this is where you've landed, Luke. And I hope the Owen team, helped get you there, which is really exciting. So anyway, thanks everyone for joining. And I believe we'll see you next week.
Okay, well, thank you so much for your time, everyone.
Thanks.